Good morning, everybody, and welcome to another Insight AppSab webinar over the Zoom network. And thank you all for joining us this morning. To start with, I'd like to acknowledge the traditional owners and custodians of the land on which we're meeting and pay my respects to any elders past, present or emerging. And I'd like to extend that welcome and respect to any Aboriginal or Torres Strait Islanders that might be joining us on webinar land. So thank you and welcome. My name's Jim Hunt, and it's going to be a good pleasure for me to be able to welcome Jeremy Hayllar in a minute, who's going to talk to us about some new things that are happening in the world of the MATOD networks. So without much further ado, I'm going to welcome Jeremy Hayllar, who's going to talk about the changes that are happening there.
Greetings, everyone. Thanks very much, Jim. So we're titling this talk Another Milestone for MATOD, and principally we're going to be talking about the long-acting injectables which have come along in the last 12 or 18 months. We also want to stand back a bit and get a wider perspective, just listing disclosures and stuff, and a number of the slides in this talk have come from the two manufacturers of the long-acting injectable products, though of course comments that are made of my own. So we'll just touch on opioid use disorder, a brief history of QOTP time. Did you know that it's 50 years since methadone arrived in Australia in 1970? So that's a bit of a milestone, isn't it? Then we'll look at buprenorphine, how that was developed. I'll mention Tasmania. And then we'll come to some challenges, a couple, I think 3 patient vignettes, and just a little bit of future gazing, which it's always good to look back on in a few years' time. So I put this slide up on a previous talk. The challenges for opioid use disorder, it's certainly not going to disappear. It's going to be with us long term, I'm sure. A recent editorial in the New England from Nora Volkov from NIDA in the USA pointed out that each day in the States there are 185 people who die from overdose. So back in 1690, I think, Sir Thomas Sydenham, who described Sydenham's career, streptococcus infection related movement disorder, he recognized the effectiveness of opioids for the relief of suffering in broad terms, so not simply pain. And I think this is one of the reasons that opioids will continue to play such a large role in substance use disorders. Other features, more recently, we've had somewhat reckless promotion of long-acting opioids for the treatment of pain. And we're all aware of the role of the Sackler family, who have currently offered $12 billion to settle all the outstanding lawsuits in the States. And it doesn't look like the States are going to buy that. So they may well be facing bankruptcy as a consequence of the legal actions. Pain and dependence, there's a growing interplay and understanding. Coming on top of all that, we've got the growing role of synthetic opioids. That's principally fentanyl and its derivatives. Now, they haven't really hit Australia in the illicit, the street markets yet. It may just be a question of time. And one of the factors that may be playing a role at the moment is COVID and reduced international flights and shipping restrictions, which means that a more concentrated opioid occupying less volume, will provide a much more marketable product because it's easier to transport across borders. We know that codeine was the commonest opioid being misused, accounting for up to 70% of patients. It's now been rescheduled, and preliminary evidence suggests that there have been no unwanted or adverse effects from that. So it's been a successful public health intervention. We've seen tamper-resistant products, which have had limited success, some perhaps, though not as much as might have been promised. There's been a lot of discussion of real-time monitoring of prescriptions. So QScript is the local product. Unfortunately, with COVID, that's gone on hold. So the implementation date for 1 July this year may have been put back 12 or 6 to 12 months anyway, unfortunately. And that's going to make it much harder to go to multiple prescribers and access these S8 products. I saw a woman last week who in the space of about 6 months had seen more than 30 different GPs to access oxycodone 5 milligram scripts. She looked so innocent, butter wouldn't melt, but there she is going around different doctors asking for oxycodone to manage her period pain and her endometriosis, which was very mild. So I've highlighted those long-acting injectables, and we'll come to them. And I think we have to recognize the steps taken for a harm reduction framework in opioid treatment, with the availability of Nixoid now, intranasal naloxone, which is available from a pharmacist over the counter, therefore without a script. Unfortunately, it's not so cheap as one would like, so almost $50 for 2 intranasal administer, so 2 doses, $50. So this is going back to 1965 with Vincent Dole and Marie Neiswander. This was the team that started using methadone to treat their patients. And it's a really nice paper to read because they describe the effects of methadone. And 2 of their patients wanted to go out on leave one evening, and they were really worried that they were going to score drugs. But what they wanted to do, in fact, was buy an ice cream. And they came back, and the dose lasted 24 hours. They weren't climbing the walls with withdrawals and cravings. And it's just shows how things can change. So as I say, the 50th anniversary, we had Dole and Neiswander in New York. They became a married couple. I don't know whether their work brought them together. I presume it did. In 1970, there was a small clinic opened in Parramatta by a psychiatrist, Stella Dalton. So that's where the 50th anniversary comes from. For a long time, there was one product, methadone syrup, and work in the 90s from Shane Dark and others showed that more than half of patients on methadone had actually injected the syrup at some stage. And that was part of the drive to develop Biodone, which reduced the other components of the syrup. So ethanol, you can see there, sorbitol, glycerol, those are sugars which counter the bitter taste of the alkaloid methadone. However, they don't produce caries. Caramel, anise, spice, flavoring, and water, those are the components of the syrup. In 2000, Biodone came along, just liquid water, methadone, and a coloring agent. And there was a presentation at APSAD in 2003 where more than half the patients said they either preferred it or had no preference. So it was a successful innovation. Interestingly, there have been several trials adding naloxone to methadone. We're familiar with that with buprenorphine, but here it is in the context of methadone, and a couple of names there, Naldone and Namico. They don't seem to have got very far. There was even a study in Sydney with James Bell et al. Just a few patients, 50-to-1 ratio, so 50 parts methadone, 1 part naloxone. And of course, the scheme there is that it will dissuade anyone from injecting the material. There's also been work on the 2 different forms. They're called, in scientific terms, enantiomers, and don't ask me to explain that. And interestingly, it's just one of those 2 enantiomers which is active, the R enantiomer. And it's been nicely shown that the levels of R methadone vary quite widely between individuals who may be on the same dose, but their likelihood of using illicit opioids when they're on the program is very much in proportion to the R level in their bloodstream. So we have a kind of unwritten rule that when someone's on 60 milligrams, that's an effective treatment dose. We could finesse that considerably if we were looking at their R methadone levels, because there's more to it than simply the overall dose of that mixture. And in Germany, it happens that their opioid treatment program just supplies the R enantiomer. And the analogy can be made with des-venlafaxine. You're familiar with the parent product, venlafaxine. The argument is made that des-venlafaxine is just the active agent, which may avoid some of the side effects produced by the combined product. Unfortunately, it is slightly more expensive. It's not licensed in the States. It does seem to protect to some degree against QT prolongation, which you'll be aware is one of the risks with methadone, particularly with increasing doses and interaction with other medications. Some of you may be aware of LAM, levo, alpha, acetyl, methadol, which was greeted in the 90s as an even more long-lasting opioid, which might allow patients to dose just 2 or 3 times a week. Unfortunately, that had unwanted QT effects. I'm not sure they were so different from methadone, but I guess because it was a newer and less established product, it was withdrawn in Europe in 2001. And I think it's still licensed in the States, but I don't believe it's used much. So that brings us to buprenorphine from methadone. Picture top right is from the Reckitt Benkiza / Indivior team. So Rowley, Ed Johnson, Martin, Jerome Jaffe, and Jasinski. And these were some of the clinical scientists who were involved in developing buprenorphine as a treatment for opioid use disorder. So while it was discovered in 1966, it was first used in 1988 to treat opioid use disorder. A few years ago at APSAD, Ed Johnson, so the guy on the left with the beard, gave a talk about a history of buprenorphine, and he described how they gave 2 milligram doses to patients, inpatients on their ward, and they would creep around at night to make sure they were still breathing because they were so worried that this highly potent opioid might tip them into respiratory depression and overdose death. Of course, that's a long time back, and now we have a far better understanding of buprenorphine. We know in 1995 it was approved in France in primary care, so it was rolled out across every general practice in the country. And the effect on overdose deaths, which had been climbing rapidly from heroin use, was dramatic. So they dropped by 4/5, so 79%. So in terms of that public health goal, it was a very effective intervention. I think Australia was maybe the 3rd country to have buprenorphine available in 2001. That was the tablets, so the Subutex. And then in 2006, the tablets with naloxone were introduced, so that was Suboxone tablets. And then in 2011, the film came along, and most of you, I think, will remember that, and the tablets were gradually withdrawn. Interestingly, there's a paper from 2009 with White as the senior author, and Maria Makowska was a co-author from Roma Street Clinic. And that was a trial looking at probufene, which was a product with either 2 or 4 polymer rods about the size of a matchstick, introduced subcutaneously into the medial upper arm with buprenorphine dose that lasted 6 months. So each rod had 90 milligrams in it. And you'll see later when I show you the levels, the serum levels from the long-acting products we now have, that these were really giving very limited long-term protection. So between 3 for the 2 rods and 7 for the 4-rod polymer rods, nanograms per mil. And remember the magic number of 2 nanograms per mil. That's where we think effective protection from overdose and cravings seems to kick in. So that brings us to the recent history. Then last year, there were 9 different doses of long-acting injectable products available in Australia. And we were fortunate in Metro North to gain experience with both the Buvidal and the Sublocade at an early stage. Just a brief diversion to Tasmania. Of course, Tasmania grows the poppies. That's a company called Tasmanian Alkaloids. Naramco, which is jointly owned by Tasmanian Alkaloids, process the poppies in Tasmania into thebaine. Camurus, which is the Swedish company that make Buvidal, they purchase the thebaine, export it to Sweden. Retchen, which is another company based in Malmo, in Sweden. They produce the long-acting injectable buprenorphine from the thebaine, and then Camurus in turn exports the products from Copenhagen, which is the nearest major port to Malmo, to Sydney and many other parts of the globe as Buvidal. So each dose of Buvidal has traveled extensively, I think you'll agree. The shot that lasts a month, this was NUA, which is a user forum published just last year in July, showing the kind of excitement that was being generated with all those balloons. So we shouldn't lose sight of the hazards of opioid use disorder for the user. The natural history is between 1 and 2% mortality each year, in large part from unintentional overdose. The figure of 1 overdose in 6,000 doses of heroin is used, I think, to illustrate that often for reasons that are not entirely apparent, what seems like the same dose, the same shot turns out badly for an individual. In our opioid treatment cohort, they're getting older. We all recognize that. And we recognize the injection-related complications, sepsis, endocarditis, discitis, for example, the blood-borne viruses leading to Hep C, particularly causing cirrhosis and hepatocellular carcinoma. And we've certainly, unfortunately, seen a number of deaths in the last 5 years from this complication of Hep C, often fueled by alcohol excess. Tobacco-related disorders in our population lead to ischemic heart disease, chronic obstructive pulmonary disease, and of course, mental health disorders very co-occurring in this population. So even in a cohort of opioid treatment patients, the standard mortality rate is significantly increased, between 4 and 10-fold the normal, inverted commas, healthy population. A range of factors: overdose, suicide, trauma, and the chronic diseases that I've mentioned. And these are fairly consistent numbers going back to Degenhart's study of New South Wales, almost 500,000 patient days in treatment there, Hayllar and others, and recently Pierce from British Columbia. And I've just put a couple of graphs up from that Pierce study. They look back over about 20 years of treatment, 55,000 patients, about 7,000 deaths. And what we can see there, top left, is on opioid agonist treatment, the standard mortality there with buprenorphine in blue is about 4-fold, and with methadone is about 8-fold. And that's weeks since starting opioid treatment. So you can see a slow decline there, particularly with the methadone patients. That's a log scale. So each increment is a doubling rather than just, yes, you understand what I mean, I hope. So we know that the risks of starting opioid treatment are accompanied by increased risk of death, which slowly declines over time. What we can see on the bottom left is that off opioid agonist treatment, the risks of death in that first couple of weeks are dramatically elevated. There we can see for methadone in yellow, that's probably 80-fold increased risk, which descends to about 20-fold in week 2 and hovers around that level for the first 3 months. Slightly lower rates for buprenorphine. Nevertheless, very significant. So that time when a patient drops out of treatment is very high risk for overdose death. In British Columbia, they've had significant fentanyl use and overuse, and we can see that buprenorphine there or opioid agonist treatment is also protecting very significantly from fentanyl-related deaths, keeping overdose deaths relatively low. So in January 2019, these products started to become available. They're both now on the local, on the list of approved medications in Queensland. So they're approved by the TGA. We no longer have to get special access approval to use them. You may be interested in the pricing. So for a month's long-acting, the price is about $370. And for a week, that's the Buvidal products, that's about $92. And interestingly, whatever the dose, so there's 5 separate doses for monthly treatments and 4 for the weekly treatments. The price is the same. So in both cases, the product information says that these are licensed for patients who've stabilized for a week or more on sublingual buprenorphine products. So to eliminate any risk of precipitated withdrawal or sensitivity to buprenorphine. So we had just over 50 patients on trial programs, which represents slightly more than half of our total patients on buprenorphine. And it was very apparent early on that there was greater convenience for patients. The benefits of not having to go and dose at pharmacy regularly, they're hard to measure, but they're certainly very evident. One of the things that's been discussed recently is people who make unexpected encounters in pharmacies and outside pharmacies, and this can lead them in the wrong direction. So not having to go to a dosing pharmacy actually may be quite a big deal for many patients, though of course for others this may be their single outing of the day, and it may provide a significant social component, getting a good working relationship with their pharmacist. So in a sense, it's horses for courses. The cost for patients is significantly reduced. Remember, the costs of opioid treatment supply from a pharmacy is around $150 per month. Once you've received the long-acting injection, we haven't yet heard of any cases of diversion. So this medication is certainly not to be given to the patient for obvious reasons. Once it's been injected by the health practitioner, it seems to be there safe, and the risk of diversion is minimal. And this may in turn lead to improved adherence, though we'll talk about that a bit more in due course. So we've now got about just over 80 patients who are pretty stable on long-acting. So this is a comparison between the buprenorphine products. So on the left, we've got Subutex, which behaves similarly to Suboxone. Then we look at Sublocade, which comes in 2 strengths. Then we go to Buvidal weekly, and then finally we've got Buvidal monthly. And you can see those 2 small red crosses on the graph. Those are the 2 average serum levels produced by probufine. And you can see they are well low compared with the current long-acting injectables. So that just highlights perhaps one of the reasons why probufine is not more widely used, because it really wasn't meeting that 2 nanogram per mil threshold that we look for. So this is a slide from Camarus. That circle I've made of the volume in the ready-to-use pre-filled syringe, it should actually be 0.64 mils, not 0.67. I'm sorry about that. So you've got 4 weekly dosing options and 3 monthly dosing options. And typically one may allocate a patient a weekly dose based on their Suboxone or buprenorphine dose. And then once one has seen stability there, move to a monthly. Or with greater confidence in the product and the patient, one might move directly to monthly. So these are ready-filled syringes. It's a 23 gauge, quite short needle. It's not required that it's stored cold, so there's no cold chain. It's given subcutaneously, so not intradermally or intramuscularly. We steered away from the use of the depot word, which is common in the rest of other jurisdictions in Australia and overseas, to avoid confusion with mental health long-acting injections, which are depots and which are typically stored in an oily medium which is injected into muscle. So this is different. We wanted to avoid any kind of confusion with depot products, which may have somewhat stigmatizing implications. And we also wanted to make sure people recognize that they're subcutaneous and not intramuscular. And one of the big no-nos is supplying a product to the patient directly. So here we can see the sort of smoothness of the dosing. You've got the darker dotted line there showing the time over 7 days. So a smooth rise and then a gradual decline. And the peak is about in the weekly dose, it's about at 24 hours. So here was a trial, and really this is the sort of standard you want to see. This was a trial against sublingual bup, which we know works. So as we'll see later, there was also a study against placebo, which is of less moment, I think, because we know placebo doesn't work in the same way that the active control does. So here we have patients on Buvidal as against sublingual bup. There were two groups, one illicit users entering treatment and those also who were on treatment. And what we can see is that there was very good retention, which was really no different between the two regimes. And there were improved urine test results. So opioid negative samples were somewhat greater in the long-acting injectable group than in the sublingual group over that 24-week period. Long-term safety data for patients showed good retention at 1 year, so a 73% retention. So this study was across Europe, the US and Australia. We had 4 sites in Australia, none in Queensland, unfortunately. Open label, looking at a kind of more of a random sample of patients rather than specially selected ones. And what we can see there is that the graph top right shows the open circles, the newly entering treatment. They slowly reduce their use of illicit, so slowly stopped their positive urines for drug screens, whereas those who were already stable on treatment, they pretty much stayed with an 80% or so negative urine drug screens for other opioids. And they were joined at a year by those who'd come into treatment fresh. So that shows us that change doesn't happen overnight. It's a gradual process, and we get there. And what about the patient feedback? Well, we know that 83% suggested that the treatment was either much better with the long-acting injectable or slightly better. So really very small group who weren't satisfied. So what are the clinical issues? Well, at the moment, the guidelines in Queensland, we have to have someone who's stabilized on treatment for 7 days, although in New South Wales, they are introducing people directly onto treatment after a test dose of buprenorphine. And I'm sure that's the way we will go eventually, though we haven't done that yet. We titrate and dose according to treatment and response. So there's a rough table to translate across from the daily dose of buprenorphine to the weekly dose to the monthly dose. I put a circle around the 18 to 32 because in most circles, we really feel that 24 is probably the upper limit of likely efficacy. So someone on 24 milligrams of Suboxone daily may well settle down on 128 milligrams of Buvidal monthly. Above that, it seems less certain. Point out that the volumes involved are really quite small. So the largest is that 32 milligram weekly dose. Interestingly, the 128 monthly dose is quite a lot smaller. Because it's a long-acting agent, the way half-lives work, it takes several injections in succession to stabilize fully. So that means you've got a bit of leeway either side to administer the next dose. And it means that over a period, a bit like we say with Methadone, each time you dose, you've got some of the previous dose present. So you are getting a dose increase, even if it's the same number of milligrams. So the same sort of thing applies. And it takes 3 to 5 doses before someone will be in an absolutely steady state. If the dose proves not to be holding, then the product information allows you to top up with a weekly dose of 8 milligrams up to 24 hours apart, though the ceiling of 132 milligrams per month is still applied. Now, again, down south, they've kind of pushed the boundaries a bit. And in some cases, people are on 128 milligrams each 3 weeks rather than each 4 weeks. And in some cases, people are on 160 milligrams per month. So having more than is recommended in the PI, really driven by clinical need. And let's not forget that buprenorphine is a medication which we understand very well now. And we know that there's a plateau effect for respiratory depression action. So it's inherently a safer drug, and therefore giving more doesn't have as much risk as, for example, we would see with methadone. There have been a few adverse effects at the injection site, only one which was quite marked with an injection that was photographed and circulated. Overall, though, apart from some discomfort with introducing the needle and then injecting the product, so most patients have a little bit of pain, not too bad. The more slowly, within reason, you can administer the dose, the better. Remember, though, giving 0.16 mil slowly is a challenge as well, because it's such a tiny amount. On the pack insert, it says, don't worry, there's still some product in here, even though you can barely see it. And that's absolutely right. So now we'll switch from the Camerus Buvidal to Sublocade. Now on the LAM, as I say, that was from the 1st of May. So they've taken a slightly different dosing strategy. They just have 2 doses, 300 milligrams or 100 milligrams, and they're given monthly. So the dose is higher. So, sorry, the volume is higher, 1.5 mils in case of 300 milligrams or 0.5 of a mil in case of 100 milligrams. And one dose is roughly every 4 weeks. The area of injection is more limited, just into the abdomen. The peak effect is seen at 24 hours. And in case of Sublocade, there is a cold storage requirement. So there's a cold chain. And as things stand, it's the final 7 days where you can remove it from cold storage and administer it to your patient. After that, the product needs to be discarded. I do believe, though, that there are possible changes afoot which will extend that non-refrigeration time significantly, though we don't have details on that yet about the timing or the quantity, but there is light on the horizon, you might say. And again, as I've emphasized earlier, we don't dispense it to the patient. So you can see there that map of the abdomen, and broadly you rotate your injections clockwise, 1, 2, 3, 4. And, you know, there may be a persistent lump from the Sublocade, which we don't see with the Buvidal, over several months. One patient described how he was admitted to hospital and the treating team saw all these lumps in his abdomen and they thought he was injecting himself with opioids. And he tried to explain to them, but they really wouldn't believe him, which is a bit surprising. Anyway, he got there in the end and was able to continue on his Sublocade. So this is just showing the serum levels from the monthly dose. And there's quite an interesting comparison with Buvidal, which we'll come back to. So the levels produced by the Sublocade are certainly somewhat higher, though interestingly, the study where patients were either kept on 300 or continued on the standard induction, which is 2 doses a month apart of 300, and then continuing on 100, the outcomes were the same for both groups of patients. So I think there are probably some psychological reasons why people would want to be on the maximum feasible dose. In practical terms, though, we can't point to any significant benefits from those populations which have been studied. And perhaps here we've got an analogy with methadone, where most of our evidence for efficacy goes up to about 120 milligrams of methadone daily. And beyond that, we see individual patients who seem to need more. We don't have good trial evidence to support improved outcomes in such patients. So you can see there that the trough levels and the peak levels are well above that 2 nanograms that I mentioned. And they're not actually so different. So the ratio there is 2. And I'll come back to these ratios a bit later because they may have some relevance. So this just shows what happens with the serum levels at the 2 induction routines. So the kind of recommended approach is 2 doses of 300 a month apart and then 100 milligrams. And as you can see on the left, we reach a pretty steady state at around 3 nanograms per mil, with that peak, early peak at 24 hours, which soon settles and gives the effect really of someone on a syringe driver. They've got a very steady release of buprenorphine from the Sublocade injection. Whereas and so that steady state is reached within 8 weeks. Whereas if we're on the Sublocade, 300 consistently, then our serum levels are going to be higher, around 5, and it takes 4 to 5 months before we reach that steady state. So that just shows kind of what's happening in the body, as it were, and in the brain, I guess. Now, the particularly interesting feature, I think, of Sublocade is what happens when someone stops their treatment. And what we can see here is that for at least 5 months after someone who may have been on 300 milligrams monthly, there is good protection against overdose and a very, very slow decay in the serum level. That's also seen in the 300-100 group, but obviously the levels are not as high, so one reaches that 2 nanogram per mil magic point rather sooner, but still a couple of months after ceasing. So we're kind of going to be very interested in what happens to patients who continue to feel well for long periods after their last injection. Do they still return to see us? Do they feel they're cured? How are we going to manage this? If they're not getting any withdrawal symptoms, how keen are they going to be to come back to renew their long-acting injection? It's an interesting point. Some of the patients in the trial that was for which Sydney was one of the sites, I think 5 out of their 8 patients kind of stopped turning up after a few months, and we don't really know what happened to them. So were they cured? Did they overdose and die? Did they go back to using? We really don't know for sure. So I think trying to monitor and keep a good handle on these patients is good, and that's going to be part of our kind of education to discuss with patients that in order to stay well, they should consider coming in regularly, a bit like taking their insulin. They take their monthly long-acting injection and they thereby stay well. So here's the trial from Haight in the Lancet showing that the placebo group, and this is probably not a study which would have got up in Australia, but I believe that the TGA, the FDA in the States insisted on it, showed the placebo group do badly, and that's not rocket science, is it? And showing that the outcomes in terms of maintaining abstinence and continuing to participate were really the same between the 300 arm and the 100 arm. And that followed patients for, there we see 170 days, 6 months. Okay, so the same provision applies, though I think over time we will see that relax. So 7 days buprenorphine, initially 300 milligrams for 2 doses. Now we've had a couple of patients who were on less than 8 milligrams of Suboxone. So we figured from first principles, it would be more sensible to start them on 100 milligrams, and they've done absolutely fine. So that's unfortunately slightly outside the product information, but it seemed the right choice for that particular patient. And that's what I'd advocate if I was being asked about someone on less than 8 milligrams per day. So once they've had the 2 monthly doses, it's a decision point whether they go down to 100, assuming they're comfortable and well, or they stay on the 300. As we've seen, the trials really don't see any major difference between those 2 groups. So Sublocade says we shouldn't give repeat monthly doses less than 26 days apart, but we do have a bit more leeway at the other side, up to 14 days late. So 14 days after that, 28 days, if you like. And just another anecdote, we had a patient from Sydney who was on their CoLab study, which is looking at long-acting buprenorphine Sublocade. And he relocated to his family in Brisbane. And for a couple of months, he was flying down to Sydney to have his injection. And then, of course, the borders shut, so he was stuck here. And he actually went 68 days between his last injection in Sydney and the first 100 milligrams in Brisbane. Because his care was kind of transferred, ethics had to be sorted with the study, et cetera, et cetera. 68 days, and he had some minimal psychological side effects, no features at all on clinical examination. So his ooze was zero. So this is a striking interval between doses without symptoms, isn't it? And if needed, one can top up with sublingual bup to carry someone through to their next dose. That's happened very rarely with us, if at all. Because the volume, partly because the volume is bigger, there is a bit more local reaction perhaps, although perhaps not quite as much pain. I don't know whether my colleagues would agree, but it strikes me that the Suboxone doesn't have quite the same pain, even though the needle is a 19 gauge rather than the 23 gauge. We do see lumps when patients return, and that's one of the reasons why you rotate the sites. But clinically, they don't cause any symptoms. I guess if you've got someone who's doing bodybuilding or modeling, they wouldn't want lumps to be present. So that might be a reason not to choose Sublocade. Here's a breakdown of the cost. I'm afraid Methadone is still very cheap indeed. And just I know in the UK, one of the reasons for reticence about take-up for buprenorphine was the cost implications, because Methadone is so cheap. What you can see again is that whatever the weekly or monthly dose, whether it's Sublocade or in the monthly, or Buvidal in the monthly, or Buvidal in the weekly, the cost is the same, interestingly, and that's in contrast to Suboxone. So someone on 32 milligrams of Suboxone, you know, that is going to be a greater cost somewhere than being on a monthly long-acting. Having said that, these costs are fully covered by the PBS, the generosity of the federal government, so they do not impact on our budgets or the patient's pocket either, which is, I've got to say, a very good thing. This comes from the Camarus website, and clearly this is looking forwards at the potential market for sales of long-acting. And just think back to 185 overdose deaths a year, maybe less than 10% of those in the States with opioid dependence accessing proper treatment. So there is enormous potential for these products. So let's turn to our own experience. As I said, we've had about 82 patients. Most of our patients on Sublocade are on the 100, only one is on 300, that's Melaleuca data. About half of our Buvidal patients are on 128, and then a smattering across the way. And I've got one lady who's just on 8 milligrams weekly because she was on 2 milligrams of bup or less. So she wanted to get away from the sublingual dosing, and she's now on the weekly dosing, and I think that's going all right. So we have a bit of discussion with the case manager or the whole team. It's often something stable patients will look for. I think there's also a role for the less stable patients who keep missing doses, who have financial problems, transport issues. So the patient I mentioned earlier, who's been to see 30 GPs, she is not good at all at getting to pharmacies. So my plan is that on Friday, we'll get her on long-acting and really settle things down. We have had 3 patients transferring from Buvidal to Sublocade because they found the 128 milligram Buvidal wasn't holding them. And we've got a couple on 128 milligrams weekly. And there is a 160 milligram Buvidal product that hasn't yet passed through PBS, though it may be on its way. So that may address some of this kind of earlier dosing that's been required to keep symptoms at bay for some patients. We've had 3 who've returned to Suboxone. One in particular hated needles and just got in such a panic, despite trying to ice the site and prepare him. He just freaked out every time he was confronted. So it was his choice to go on to the long-acting and his choice to come off. And a few patients have left the program, and this is a group that I think we have to try our best to follow up. Overall, the response has been very positive from patients. And just mention in particular 2 patients with persistent pain who've really found very effective relief from the long-acting injectables. And that kind of highlights this idea of almost an opioid infusion happening rather than the relative ups and downs of the sublingual product. So what are the implications? And I've taken these 2 next slides from Nick Linzeris's talk at IMIA last year. I've edited them a wee bit. So I think we've still got a big potential for changes to medication-assisted treatment of opioid use disorder in Australia. We're getting away from the whole concept of supervised dosing, which was an informing principle, and the whole discussion around takeaways. Perhaps our services have been less obsessed with UDS than down south. In some jurisdictions, one needed to have a series of negative UDSs to qualify for takeaways. We've never practiced quite that strictly here. Nevertheless, there may be a reduction in UDS roles for patients who appear stable. So the costs I've mentioned, the diversion I mentioned, and it may be a reason for less conflict between providers and clients, because often this takeaway issue is a real bone of contention. And it's great that we've now got a confirmed choice between the 2 different products, with the Sublocade reaching the LAM on the 1st of May. So is it going to attract methadone patients? Well, I've heard of 1 or 2, but not yet a rush, but perhaps it's early days. And what are the implications going to be for our public clinics? I know in New South Wales there was some concern that there would no longer be the need for as many case managers. I don't really see that as likely in the future. Hopefully what it's going to allow is more value add for patient care and support, less time spent negotiating with patients and pharmacies and scripts or written instructions, and more time trying to provide support to patients of a counselling and psychological nature. Are services going to become depot clinics? That's a term from the South. We're calling it long-acting injectable, as I said. Well, I don't know. There's apparently, in Victoria, there's a move that may see pharmacists giving the long-acting injectables. Word from Queensland is that is not contemplated, but you know how these things sometimes have a domino effect. What about the relationship between the specialist clinics and primary care services? We've got a shared care project underway in Metro North. The long-acting injectable may add further opportunities for that to spread. I know that my colleague Tom O'Gorman in Westmorton is really keen in the prison, the custodial setting, and I think it ticks a lot of boxes. I think we still need to ensure that patients consent, because what I've also heard, and this is again gossip, is that patients leaving the custodial setting in New South Wales, where Sublocade has been available in a trial setting, have been reluctant to continue it, and they want to go back onto the daily dosing, in some cases perhaps, because they felt they were forced into long-acting injectable. And that's just gossip, and forgive me if it's not correct. So we've got some challenges which have been partly resolved. The patient who's on a long-acting injectable needing urgent surgery. Well, we use alternative approaches. So ketamine is recommended. I was discussing this with an anaesthetist at Prince Charles last week. Epidural blocks, local blocks, regional blocks. Fentanyl has a similar affinity for the mu opioid receptor, so it's the logical opioid to choose, I think. And we heard from WA, a surgical patient whose treatment really consisted with ketamine, fentanyl, and pregabalin in the perioperative period, and they did very well. So a bit like Suboxone, initially we were very scared about the blockade it would provide and interfere with good anesthetic practice, that really doesn't seem to be a legitimate concern. Of course, we're still to get more experience, but as things stand and based on first principles, I think that's a reasonable conclusion. As I've said, the custodial setting, I think there, one of the problems is how do you make sure you diagnose opioid use disorder properly? It's said that if you want to halve your sentence, you go on to opioids. If you want to double it, you go on to methamphetamine. You can see the point there. Does the lump of Sublocade represent a risk for diversion? We've got no reports yet, but I suppose there's a theoretical risk. In the US, I understand that someone stable on 100 milligrams of Sublocade a month who wants to travel for 2 months, they can opt for a 300 milligram dose and cover that gap beautifully, which shows the flexibility which will continue as we gain more experience. Now, one group of patients I do worry about are those who want to keep their dose high enough to manage withdrawals, but low enough to use on top. Now, some of them will be transitioning from a using model to a kind of abstinence model. Others, this is a long-term decision that they're making. So if they're on methadone, they might miss their dose. If they're on Suboxone, they might avoid their dose on payday, for example. What happens to these patients over time? I don't know that we've got a good understanding. Are they likely to choose the long-acting? Should we be encouraging them into this? And it's kind of a bit of a conflict between the harm reduction and the abstinence model. So one strategy I use is I ask patients, do they want to stay on opioid treatment long-term? How long do they envisage? Where do they want to be in 5 years? And I sort of set them a 2-year alarm or a 2-year clock to gradually decline over time. And each time they use, they set that clock back to 2 years, with the idea that once they've achieved 2 years abstinence from using on top, then they're much more likely to be successful in trying to withdraw off the program. And certainly LAIB could be very helpful in that regard. What about switching between the two products? The ones we put on to Sublocade from Buvidal, I mentioned the 3, we put them on the 7 days in between. Now, I think in theory, they should be largely interchangeable. After all, it's the same drug in each case, but we don't have experience in practice. So I think the precautionary principle will apply, at least till we've got more experience. And what about inducting directly from heroin or other agonists? Well, I think that's coming. I think it's certainly arrived in New South Wales. So people may get a 4 milligram test dose. I think that's in their guidelines. And then once all's well there, then they can go on to the long acting. I mentioned that patient from Sydney. I've mentioned the patients who decide they don't need buprenorphine because they're getting such a long tail, a very slow decay. We need to try and follow them, though that may not be easy. What about clinics in non-metro that don't currently dose their patients? They don't necessarily have an S8 fridge, or certainly not a fridge, but an S8 drug cabinet. What's going to happen there? And finally, anecdotes, patients seeking to switch back from Sublocade to Buvidal because they miss the Buvidal buzz. And that might be particularly with the monthly, the monthly doses here. We can see there's a 10-fold ratio between the level at peak and the trough. So when they're having injection, they're really getting quite a quick onset of the product, in contrast to Sublocade, which only has a 2-fold ratio. So I think that probably explains why there is what I've termed a Buvidal buzz that people may miss. And overall, it's probably not something we should be encouraging or promoting, is it? Because what's been so good about buprenorphine is its kind of transparency and lack of significant opioid agonist effect. So I've got 3 patients that I was going to discuss, but I think I've run out of time. So I might go to my last slide. I'm sorry about that, but these will be up, I guess. Last slide. So anyone seen this newer document? It's a really good, I think it's 32 pages, so it's quite detailed. It's a user's guide, and it's really very helpful, and I learned stuff reading it. On the right, you can see our clinical guidelines for the long-acting injections. We don't use the word depot, as I've highlighted. Here we've got Victoria, New South Wales, South Australia. And for current prescribers in Queensland, there is an extra online requirement, which is available through Insight. That's the address there. And once you've completed that, I'm afraid there's various people talking, including oneself. Sorry about that. There's a form to do, which you submit to MMU, and then you can get an approval. So final slide. Sorry if we've... Anyway, will LAIB become the new normal, as we're now calling it, rather than business as usual? Give it slowly. That's the message for anyone administering it. I'm sure there's going to be a role ongoing for methadone. So perhaps when we reach the 100th anniversary, for which I don't intend to be around, it'll still be playing its part. I think we need to increase the emphasis and focus on take-home naloxone in opioid treatment clinics generally, and in our own backyards particularly. Queensland's been quite slow compared with some of the southern states. So I really want everyone to get their act together, please. We've had great feedback from patients, and particularly pain patients. So I'm sure that the companies may be looking at this as a new indication for the LAIBs. I've mentioned again and again, those who forget to return for their monthly dose. We need to look out for them. Codeine rescheduling, that has delivered the desired results. So Dobbin looked at this just a few weeks ago in the MJA. 2 papers, 1, fewer codeine-related overdoses, and 2, reduce codeine sales. So it hasn't been replaced by people using other opioids either, which was the big panic that was being spread. Q-script being delayed, although that will, I think, bring a fair number of patients across our doors, because their routes for obtaining S8s will suddenly dry up if it works according to plan. We need to think about primary care, private prescribers, shared care models, retail pharmacies, I mentioned that. Fentanyl, you know, this is a growing issue around the world. It's synthetic. You don't need Tasmanian poppies for fentanyl. So I think this is something we need to be very mindful of in the future. And finally, a global recession related to COVID. That is likely to push more people into desperate straits. Case and Deaton described this very well in the States, deaths of despair, they call them, from overdose, from alcohol related to cirrhosis, and from suicide. So the suicide issue has been significantly discussed with funding for mental health issues. In a sense, that's almost at the bottom of the cliff, isn't it? All right, thank you very much for your attention. I'm sorry if I've used almost the allocated time.
Thank you very much, Jeremy, and certainly do not apologise for running over, because it's always a pleasure to learn. I actually have a load of questions from people, so providing you've got time for another 5 minutes or so, I'll start running through some of these. Some of these you might have already come across during your presentation, so I apologise if we get you to repeat some stuff. One I think we did touch on, within our clinic, what's the criteria for patient selection to go on to a long-acting injectable?
Well, just going through it, there's no buprenorphine allergy. They've been stable on a dose of buprenorphine for at least 7 days. Pregnancy is a relative contraindication, but it's not an absolute contraindication. So a bit like the Suboxone story, we've kind of become a bit more relaxed about that over time. And indeed, Suboxone is no longer treated differently from Subutex. So in some clinics, I think there's a sort of team discussion about whether this patient's suitable. We have got a bit of a wait list on the 6th floor Roma Street Clinic, but broadly we can get patients in fairly quickly. I think informed consent, we need to explain to the patient what's involved, make sure they're not petrified of needles, although don't play it up too much. One of the patients I was going to talk about is extremely thin and has virtually no subcutaneous tissue. And that's not because they've been bodybuilding and using anabolics, it's because of poor nutrition. Yeah. And that certainly makes the injections more difficult, though not impossible. So those are the broad factors I would go through.
Thank you. Now, you mentioned that for our guys coming here, there's no cost. Is the total cost covered by PBS?
The total cost is covered by PBS. Remember that the cost from pharmacy is the dispensing fee that the pharmacy charges. And one of the possible consequences of huge uptake in LAIB is that pharmacies will lose business. Now, we don't know what's going to happen there, but that could be one of the drivers for them, say, to get credentialed to do the LAIB themselves, as is being proposed in Victoria, or for them to employ perhaps a practice nurse for a session, an LAIB session.
So is there a plan within Queensland for pharmacists in the future to actually administer or just dispense?
There isn't a plan for them to administer, and remember, they're not going to dispense to a patient, they're only going to dispense to a clinician, an approved prescriber who can administer it.
Sure. And so for our guys, they no longer have to pay daily dispensing, they no longer have to pay for their script. Do they have to pay the clinic any money for the actual process of administration?
Well, this is a somewhat nuanced question, because in some clinic settings, and I can think of one halfway up the coast that's been in the news recently, they do have a custom of charging patients, so I don't imagine that's going to change. In Metro North, so our HHS, we do not currently charge our patients. There are some details about whether the product is being supplied by the hospital pharmacy, because their requirements are for patients to be billed through Medicare, so normal prescription charges. There may be ways around that. If it's being supplied to a private prescriber or to a pharmacy attached to a private prescriber, then again, there may be some prescribing fees, or dispensing fees, I should say, but that's not really been fully worked out as far as I know.
Fair play. Another question for those that don't know, if you start Subutex or Suboxone and somebody's still got opiates in the system, there's a risk of precipitated withdrawal. Have we had any experience with that with the long-acting injectables? Well,
because of this 7-day requirement, we haven't, no. And so certainly for a new product, you can fully understand why you would say, let's make sure there's no risk. Again, precipitated withdrawal, we used to be quite afraid of it. It's not such a bogey anymore. And I think, although it used to be said it happened in 20% of inductions, I think in experienced prescribers' hands, it's really quite uncommon.
Thank you. Would you top up with Suboxone if someone was on Buvidal or Subutex?
Well, the PI for Buvidal says you either top up with a weekly 8 milligrams if you need. I wouldn't worry about using Suboxone if that was required. Remember, you've got this sort of dose ceiling of 160 milligrams a month, so the PI says you shouldn't go above that.
And one of the other questions was, have you often had to top people up on the long-acting injections? Is it a frequent thing or an infrequent thing?
As you saw from that, I think Melaleuca had 17 Buvidal patients. About half of them are on 128, and I think it was 2 of them are having 128 milligrams 3 weekly. So we've certainly had patients where we thought 64 would work. We've gone to 96, and then we've landed up in some instances on 128. So it has surprised me a little bit. Nevertheless, I think we have to recognize that patients vary, and the absorption of their Suboxone may vary, and likewise the availability of their Sublocade or their Buvidal may vary. So I think we really need to base ourselves on how the patient's going, their clinical findings, and judge from there what sort of dose they're going to need.
And so that kind of leads into the next question, which is somebody wrote in and said they've got a client who's in the obese category weighing 169 kilos. They're on 160 milligrams of Buvidal. Is absorption going to be an issue when somebody's at that level? And have you come across something similar where someone's struggling even on the high levels?
Well, I mentioned we've had 3 patients that I'm aware of who've transferred from Buvidal to Sublocade. I don't think the obesity issue plays a significant part. It does make it easier to do the injections, though. So
there's always a flip
that's one
side.
positive of being overweight.
Have we had anyone who's stable on the long-acting injectable that actually then decides they want to come off opioids and actually done it in a planned thing rather than just disappear from follow-up, to see whether we can monitor whether there is that long tail and whether it's a pleasant more pleasant experience?
Great question. And this is, I think, you know, the $64,000 question. Is that going to provide a suitable route for people coming off completely? I'm not sure that it is. However, I think it may feel like it does. And I think that's why trying to stay in touch with this patient group by explaining to them, let's go back to those risks of coming off daily treatment, those overdose risks and stuff. Now, we're not going to see anything dramatic like that. Nevertheless, without the protection from overdose provided by buprenorphine, whatever form it takes, patients are at increased risk. So all the other work that's involved in recovery needs to be happening. You know, dealing with trauma, the counselling, the work, the family, the recreation, the studying, all that is in place to give your patient the best chance of thriving off the program.
Definitely. And you mentioned, just kind of following on from that, you mentioned the guy that was transferred from Sydney up to Queensland, and he went 68 days, you know, which is obviously a considerable time. In the clinic, are we noticing that people are missing coming back, as in, you know, are they delaying coming back for their injections, or are they generally coming back routinely? Because one would assume if life is good, it may be something that would slip their mind to come back.
Well, don't forget, we've got some very dogged case managers. So Gail is right onto them. And yeah, there have been a few short delays, but overall, I think people are doing a good job in terms of following patients up and them returning for their doses.
Perfect. I've got a couple of curly ones.
Oh, thank you.
Well, I say curly, you might find them easy. Has anyone of you had any cases of patients reporting a taste in their mouth after they've had the subcutaneous injection?
Good question. No, I haven't. That's interesting, because people do talk about a feeling at the back of the throat, don't they, after they've injected IV anyway.
Another one is a case which, if you want to respond to this, you know, privately afterwards, that's fine. Patient on 24 milligrams of weekly Buvidal, about to go to monthly. Prior to that was on 14 milligrams, I assume, and stable. Is now complaining of constipation despite being on some laxatives, and abdo x-ray not showing any constipation or any abnormalities. Any idea why constipation would suddenly appear if somebody changed from a oro to a injectable?
Yeah, good question. That's an interesting puzzle. I think we can just point to the steady blood levels that are being provided. So have you ever asked a patient using heroin if they have constipation? Generally they don't, because the heroin bungs them up for a bit and then there isn't any till the next morning, and nature has its way. So those swings of high and low seem to allow the bowel to perform regularly. With the Buvidal long-acting, you're not getting those troughs which might allow the bowel to wake up and perform. That's the best explanation I can think of from first principles anyway.
Sounds sensible. It was really interesting to see the start with the history of the opioid treatment. And obviously, as you will know yourself, being of a certain age like myself, back in the day, we used to prescribe heroin to people that use heroin, and Switzerland certainly still does. Do you think, I know that the licensing of it is different here, do you think that's something that would ever come to Australia?
Well, while John Howard is alive, he famously said of a proposed heroin trial in Sydney, over my dead body.
Fair enough, that probably answers that question then.
Once he's gone, maybe.
Yeah.
I mean, one nuance there is that hydromorphone is a very acceptable alternative to heroin, which has much less of the kind of loaded nature of that name. So Naomi was a study in North America where they use hydromorphone injectable as a kind of alternative for patients. And let's not forget the RIOT study, which Nick Lintzeris in the UK was involved in. They struggle to recruit patients because I guess the regulations around providing heroin to people are really quite tight. Yeah,
that makes sense. Another strange one, has there been any benefit in its use for people that use amphetamines? You thought you might get that one, I imagine, with the Australian population. It's certainly not something we would be encouraging.
No, I mean, we have talked about this a bit. There's been, you know, a little bit of data about naltrexone
Definitely.
having some benefit for some methamphetamine users. So there was a study in, I think, 2008 from Lindstrom, a preliminary study which showed some benefit with a couple of patient anecdotes. And I've certainly had some patient anecdotes. One, for example, said he didn't want to use the naltrexone because it stopped him getting a buzz from methamphetamine. So, you know, go figure.
Yeah, you can't.
We do see occasional patients on Suboxone who say they've lost their taste for alcohol. And so that could be a partial naltrexone effect. So, you know, in theory, I think there might be a remote possibility. However, in broad terms, we've decided that we don't really follow this argument that it's a good reason to put someone on a buprenorphine preparation to try and manage their methamphetamine use. That they don't have opioid use disorder, therefore we don't want to create another problem for them.
Sure. I think the final question really is about access to more information and education around this. I'd quickly say that at Insight on our website, we have ELAMP modules, which are designed for prescribers, and we have a QOTP, so Queensland Opioid Treatment Program module for those interested in that. But we also have a separate long-acting injectable module that prescribers can access with their prescriber number to go through training for that. We will also put this webinar up on our website. So again, there's more information there for clinicians to be able to review and go back and have a look at it. But regarding patients, what information is out there regarding guidelines and booklets and information for their clients?
Well, I think that newer document, which I pointed out, the Consumer's Guide to the Opioid Treatment Program, Depot, long-acting buprenorphine starters guide. I think it's 32 pages. It's actually quite a large document to download, but it's very good and it gives you a really good feel for it. So I think we would certainly encourage patients coming into long-acting or contemplating long-acting to have a read. I think it's a very good resource.